هلو يلا يعطيكم العافية جميعا ومساء الخير. خلص إن شاء الله هاي آخر سيشن لليوم، بعدين كل بروح على البيت وريتشارج لبكرة إن شاء الله. بكرة في البيدياتريك سيشن مع الأسوسيشن مع اليوروبيان هارت فور شيلدرن. في كتير متحدثين من برا فwe're looking forward for it. إن شاء الله بدنا نفس الانثوزيازم و maybe even more. Alright, so I'm going to introduce my dear friend Dr. Mohammed Hajjiri, the chairman of the Electrophysiology group. He was a bit late because of having an emergency, atrial tachycardias. He had to ablate, so couldn't be away from the cath lab for too long. So anyways, welcome, and please go ahead.
All right, thank you very much, and I'm really sorry I switched. Many thanks to Dr. Al-Makhamreh for switching with me. This is going to be a very exciting session. We're going to talk about several topics, but first, definitely, we're not going to. We're not going to be doing. بس نحكي لهم رح نغير السيشن. بس حطوا تبعيته. الدكتور رائد عواش. All right, so this is what I'm going to be talking about, but I switched with Dr. Raed. So we're very happy. Please welcome Dr. Raed Awaishe, one of our renowned private practice interventionalists in Jordan.
Thank you very much. Thank you very much. شكرا جزيلا. طبعا really it is embarrassing for me actually to present atrial fibrillation in front of great EB cardiologists in Jordan. But anyhow, this is what, for the satisfaction of my colleagues, I will go. Please excuse me if I did any mistake and correct me immediately. Okay, so what I'm actually going to present today about the atrial fibrillation and the importance of apixaban in doing that, and to introduce that this is actually for الدولية الدوائية international pharma. They introduce bayan as a medication for apixaban. I'm sorry, maybe this is for the medical education and for the ethics. We don't go for brands, and this is but excuse me, this is how your conference is going. So excuse me for doing such a lecture, but anyhow. So atrial fibrillation is, as you know, it is one of the most common arrhythmia in a human being, and this is order going to do for the heart, changing the electric system in a way that contracts very fast and irregularly. And the bad thing about atrial fibrillation that yes, it is one of the causes of cardiomyopathy, which is induced by arrhythmias or rapid arrhythmias induced cardiomyopathy. But the bad thing about it is the stroke. The worst thing about it is the stroke. And we talk about the atrial fibrillation. It is a very common problem, especially when the patient gets elderly. So it is in more than 1/3 of the patients of having age more than 65, they have atrial fibrillation, and this is really a big number. And when a patient has atrial fibrillation, when you compare it to another patient who doesn't have atrial fibrillation, and they are equal in everything, you have 5 times risk of developing stroke. And when the patient with atrial fibrillation develops stroke, he has a risk of 50% mortality in 1 year, and 50% of patients who have stroke after atrial fibrillation, they become really disabled. So really, we are talking about something, really something that we need to stop it or to prevent it, because when it happens and cause disasters. So when it comes to the classification of atrial fibrillation, you know the valvular and non-valvular atrial fibrillation, and any cause of any problem in the valve that cause especially dilatation of the left atrium and cause atrial fibrillation, we call it valvular atrial fibrillation, and we have the non-valvular atrial fibrillation, which not related to valve problem. But the most important thing about it, when you go to the classification, that the valvular atrial fibrillation that you can use that you cannot use NOAC or the new anticoagulants, any prosthetic valve and any patient with rheumatic heart disease with moderate to severe mitral stenosis. So we consider this as valvular. The others, we consider them as non-valvular, so you can use the NWAC. Am I right or not, EP cardiologist? Okay, everybody's silent, so I'm right, thank you. So when we come to the classification also for atrial fibrillation for the timing and the duration, atrial fibrillation, we call it paroxysmal when it is less than 7 days, persistent more than 7 days, and permanent when you have no treatment or return to sinus rhythm. And as I said, that when we have the atrial fibrillation, we have 5 times increment. I think this one. Yeah. 5 times increment of the stroke. Just to try it. So in this Copenhagen stroke study, it showed how much when you have a stroke due to atrial fibrillation, it is more debilitating and more severe when you have a stroke not due to atrial fibrillation, either for the length of hospital stay or on hospital mortality or discharge to nursing home. And for Framingham heart study also, when you have it, the disability that happens in the acute phase or 3 months or 6 months or 12 months, when it is a stroke due to atrial fibrillation, it is more to cause disability than non-atrial fibrillation stroke, okay? So in brief, when we say atrial fibrillation-related stroke, it is increased the mortality, 50% mortality in 1 year, the recurrence is high, and the disability is higher. So simply, we go for the guidelines for the management of atrial fibrillation. When we go for we classify them in valvular and non-valvular atrial fibrillation. And the non-valvular atrial fibrillation, we go for the CHA2DS2-VASc score. So when you have a low CHA2DS2-VASc score of 0, so you don't need to give anticoagulation. And when you have class of 1, you go for anticoagulation, and the class of recommendation here is a class 2A, while when you have a CHA2DS2-VASc score of 2 and more, definitely the class of recommendation is 1A. So definitely when you have atrial fibrillation with other risk factors, as you see here in the CHA2DS2-VASc score, as congestive heart failure, hypertension, age more than 75. When you have age more than 65, you give it 1. When you have age more than 75, you give it 2. When you have diabetes, stroke will take 2 points. And when you have vascular disease, even if you have old or myocardial infarction or any vascular problem, this is considered vascular. And the gender, we go for the female gender. So these are 9 points. At the same time, we need to evaluate the risk of bleeding. And you have the Hess blood score, where you have the uncontrolled hypertension. This is increase the risk of bleeding. And when you have abnormal renal function or hepatic function, each one takes 1. When you have a stroke, it takes 1. And we have bleeding history in the past, or liability for as a patient in INR or patient in warfarin, elderly patients, and patients who are in alcohol ingestion or drug-drug interaction. So for these patients, you give them 1. So it is good actually to know about these stuff, because it's important to evaluate the risk of bleeding and the risk of thrombosis. Anyhow, many times we see in the practice that because of any bleeding, the clinician try to change you from NWAC or to stop NWAC or under decreasing the dose. And this is actually, it is not right in the practice. And I hope that my EP cardiologist here can cover this in a better way. So when we come to apixaban, it is the most commonly used, I think, NWAC for non-valvular atrial fibrillation. And the regular dose of it is 5 milligrams twice daily. And the adjusted dose of it is 2.5 milligrams twice daily. This is according to criteria. If you have 2 out of 3, as you know, when you have an age of patients more than 80, body weight less than 60, and serum creatinine of more than 1.5. So if you have any 2 of these criteria, if you have any 2 of them, so you decrease the dose of, or you adjust the dose of apixaban instead of 5 milligrams twice daily to 2.5 twice daily. And then and the benefit, the good thing about apixaban that it showed superiority now. It is not just only that it is non-inferiority study by this Aristotle, where you have a superiority even for apixaban in top of warfarin in the patients for the primary outcome of stroke, systemic embolization, major bleeding, or secondary endpoint as the all-cause mortality. So when we talk about the superiority, yes, we have a 21% relative risk reduction in reducing the stroke and systemic embolization, and 31% relative risk reduction in reducing the major bleeding events. So you have now a superiority, even not just non-inferiority, for apixaban in comparison to warfarin. And when we go to the NWAC and to compare the NWACs between them, and this in meta-analysis of 3,900 patients, and it compares the apixaban to warfarin, it showed that there is in favor of apixaban, and apixaban also, it is in favor of apixaban on top of dabigatran, and in favor of apixaban on top of rivaroxaban in reducing the risk of stroke systemic embolization. So apixaban now is showing even superiority in this meta-analysis to the other NWAC like dabigatran and rivaroxaban. And when you continue in the superiority, how about the mortality? The mortality risk when you compare apixaban to warfarin, it is in favor of apixaban. When we compare apixaban to dabigatran, maybe they are equal, but for rivaroxaban, yes, it is in favor. And when we come for the major bleeding, in comparison to all, okay, this laser is not working. So this apixaban, all the time, it is in favor of apixaban. So when we talk about bleeding, you have a significant or in favor of apixaban better than even the other NWAC. How about the elderly? Elderly are excluded from most of the studies, and especially patients who are more than 80 years of age. And in these patients, what to do for them when you give them apixaban? It is again in favor of apixaban on top of warfarin in reducing the risk of stroke and systemic embolization in comparison to dabigatran. And dabigatran to warfarin, dabigatran is still in favor, but maybe rivaroxaban and warfarin in the elderly is not that much. Apixaban versus warfarin for major bleeding is better. Dabigatran and rivaroxaban doing the same in comparison to warfarin. So for elderly, it is safe to reduce the risk of systemic embolization and stroke, and also for reducing bleeding. How about the other group of patients or subgroup of patients when we have a kidney problem? When you have a kidney problem, actually, you don't need to adjust the dose even if you have mild, moderate, or severe impairment of the kidney function. And even if the patients the patients who have end-stage renal disease and maintained in hemodialysis, you don't need to adjust the dose even, you need to decrease it because the excretion by the kidney is in 27%. So no need to adjust the dose. When we adjust the dose, when we have another problem, as we said, the criteria, either the age or weight. So only in this case. So renal impairment alone is not a justification to decrease the apixaban, isn't it? I think so. Okay. So what's the benefit actually when we compare it to warfarin? You have a rate of thrombosis reduction. As you see here, it is 5.5, and here it is 10, and for bleeding, the same thing. So in summation, what we have a reduction of hazard ratio of 0.47 for both, for bleeding and for systemic embolization and the stroke. Reduction in comparison apixaban to warfarin in a patient with end-stage renal disease and on hemodialysis. So my key messages that bayan or apixaban, we have the Jordanian one, demonstrates superior effectiveness for the superiority and safety in comparison to warfarin and another DWAC, and associated with lower risk of stroke and systemic embolization in elderly patients. And also it is the only one which approved to be used in end-stage renal disease and it is the least to have an interaction with alcohol and other drugs as an interaction. Thank you very much. I think we are done.
Thank you, Dr. Raed, for such a great presentation. We'll leave the questions a little bit later, but
Great.
if you could join us here with the panel, we'd really appreciate it.
Thank you.
So now I'm going to also ask our other colleagues to join us. Dr. Islam Abu Sido will give us, and Dr. Ali Al-Halabi will give us the next presentation, which is Syncope from Approach to Causes and Management. And of course, Dr. Islam is a very well-known cardiologist. He's a dear friend of mine, a brilliant interventionalist. He's going to start with this case, and then Dr. Ali is going to give his perspective on the case. Dr. Ali, of course, is the chairman of the scientific committee in the Jordan Cardiac Society for Pediatrics, and tomorrow he has a big day, so we're looking forward for it. And go ahead, Dr. Islam.
Good afternoon, everybody. I'm honored, privileged to be here with my dearest colleagues. Basically, excuse me, Qais, I will leave the question at the end of the talk if you don't mind.
I think that's a good idea.
All right. So let's talk quickly about syncope. I know, most of you are aware, but it's a very familiar topic that need to be tackled. So I'm going to highlight on certain things that we have to keep in mind. So as you know, syncope is a transient loss of consciousness and postural tone followed by spontaneous recovery. Syncopal episode may occur suddenly without warning or be preceded by symptoms that include dizziness, lightheaded, diaphoresis, nausea, or visual disturbances. Syncope is actually responsible for 1 to 3% of all emergency department visits and almost 6% of all hospital admissions in US. Underlying conditions that may decrease brain perfusion can lead to syncope ranging from benign reaching to life-threatening situation. For the most part, cardiac causes are really common in elderly, while non-cardiac mechanisms like vasovagal responses are more common in young adults. The incidence of syncope does not significantly differ between men and women. Now let's tackle the causes of syncope. Number main cause is a cardiovascular disease. Remember, cardiac arrhythmia has to be excluded, including both tachy or brady arrhythmias. Structural and obstructive disorders include valvular abnormalities, mainly aortic stenosis, hypertrophic cardiomyopathy, MI, and pulmonary embolism. The second common is cerebrovascular cause, which is typically secondary to a vertebrobasilar insufficiency. And there are disorders of blood flow and vascular tone that we face almost on a daily basis. And typically that occurs typically in younger population like vasovagal, which is called neurocardiogenic. Orthostasis is extremely important. Once you face an orthostatic hypotension, then you have to exclude certain causes like medications, autonomic failure, peripheral neuropathy, or decreased blood flow. There are situational causes which are really benign, but we are mostly familiar with it. Cough might induce situational syncope, micturition, defecation, postprandial event. And we should highlight on the carotid sinus syncope because it's very common in elderly. Now, a lot of disorders manifest with symptoms like syncope, and we have to differentiate because we have a certain situation that need to be addressed, like seizures, metabolic conditions that might contribute to syncope, hypoglycemia, hypoxemia, symptomatic anemia, and psychogenic disorders like panic attacks. They're really common in practice. Now, as you know, adequate cerebral blood flow maintains the brain function by providing a constant supply to the brain. Any supply interruption, even for a few seconds, can lead to loss of consciousness or syncope. Cerebral blood flow is maintained by a complex mechanism that involves cardiac output, systemic vascular resistance, mean arterial pressure, and intravascular volume, any defect on any of these might interrupt or decrease the cerebral blood flow, contributing to syncope. Now, any episode lasting more than a few minutes is not a true syncope. So syncope is a few seconds. We have to remember that. So if it lasts more than a few minutes, that's not a syncope. And it might be related to other disorders, typically brain disorders like seizures, which might be confusing with fainting. There are terms like near syncope or pre-syncope. They are really confusing as they carry different meaning on various practitioners. When defined as feeling that one is going to pass out but does not, near syncope is related to syncope, but both conditions link to cerebral hypoperfusion. Now, the most important in order to get your diagnosis is the history and physical. So thorough history taking and physical exam is enough when the patient arrives to the emergency department. 50% of the diagnosis, we can get it by a proper history and physical. So history taking should focus on duration, preceding events, precipitating factors, and post-event manifestation. A detailed history should focus on medical problems and medication that the patient is taking. And the patient position actually at the time of the event is really crucial and essential. So syncope following, long-lasting standing might suggest a vasovagal process. In contrast, where fainting on a supine position without any prodrome might address the neurocardiac causes. Now, the physical exam, the most important part is the vitals. Orthostasis is extremely important in order to address orthostatic hypotension. Detailed cardiovascular and neurologic exam should be included, looking for signs of vascular disease, heart failure, acute cerebrovascular event, which masquerading as a syncope. Again, proper evaluation after a thorough history and physical exam. Typically, we need to do some blood tests like hemoglobin and electrolytes. EKG is extremely important, blood glucose, typically in elderly, that might present with a syncope. Even further workup, I just had a patient who had actually massive inferior wall MI present with syncope, and that's it. He did not complain at all of any chest pain. So cardiac enzymes is crucial, continuous cardiac monitoring and echocardiogram. If a cardiovascular etiology is suspected, has to be done. Now, for the most important part, our EP colleagues, they focus on cardiac event monitor, and this is really recommended for discharge of the patient outpatient and a patient who is suspected to have conduction abnormalities. So cardiac event monitor is crucial in order to reach the diagnosis. If a cerebrovascular etiology is suspected, then we should further work him up for a central causes like CT or MRI or carotid Doppler. EEG is indicated once we suspect seizures. Exercise testing is useful if inadequate rise in blood pressure occurs in young, might indicate actually ischemia or hypertrophic obstructive cardiomyopathy, and in the elderly, it's typical actually of autonomic dysfunction, which we are facing actually almost on a daily basis, those Parkinsonian plus conditions. Stress testing might unmask the EKG changes of channelopathy and actually typical scenarios that we're facing like Brugada syndrome. So we have to keep it in the back of our mind, especially in young, without any apparent cause of his syncope. Stress testing might reproduce prolonged QT interval, polymorphic VTs or heart blocks, so we have to consider it has to be done, under the close observation of an electrophysiologist or a cardiologist. Now, when do we request a tilt table test? And it has to be actually considered in the following situation. So if the episode of syncope is recurrent, having unknown etiology, and occurs in the absence of cardiac disease, we have to consider tilt table testing. Now, the diagnosis of vasovagal syncope, once it is uncertain and requires ruling out potentially life-threatening causes, then tilt table test is mandatory. Differentiating between suspected reflex syncope and orthostatic hypotension, this is also an indication to do a tilt table test. It is really contraindicated in ischemic heart disease, uncontrolled hypertension, those with significant aortic stenosis or LV outflow tract obstruction, you should not attempt doing a tilt-table test in these conditions. Now, when do we refer to our electrophysiologist colleagues? Electrophysiology study should be considered in high-risk patients with recurrent unexplained syncope. So once you face, a challenging case, immediately you have to call your colleague to do an EP study. It is not recommended in patients without underlying heart disease, so we have to be aware of this. It is recommended in ARVD, Brugada, high-risk occupation, syncope in patients with bundle branch block, suspected intermittent bradycardia and syncope preceded by palpitation. This is the time when you refer to an EP study and to your colleague who is the expert. What do we do for those patients with syncope? Always look for the underlying cause in order to manage those patients. Patients should sit or lie down quickly during an acute episode. This is basic, but we have to focus on that with their legs elevated, and to aid recovery from reflex postural hypotension, you need to keep him in a flat position. Keep patient in a horizontal position after the event, and while preventing them from standing up too soon, it's really recommended. Any injuries sustained during fall down, you have to do an immediate attention. Now, vasovagal, which is very common, which is called the neurocardiogenic, vasovagal is really very common in young people. The approach is conservative, typically, include avoiding situations, try to avoid the stimuli that trigger such an episode, engage in a tilt training, and increase salt and fluid intake. So these are the most important part of treating vasovagal syncopes: reassure, educate, and physical therapy. Now, you might be stuck with certain situations that this patient is not responding to kind of education and reassurance with physical therapy. This is the time you're going to introduce medications. Beta blockers might be helpful. There's one nice study, randomized controlled trial for the SSRIs about paroxetine that was really helpful in those patients. But keep in mind, fludrocortisone and midodrine is very helpful in this situation. And if you're stuck with a patient who has a significant trauma out of his vasovagal, then dual chamber pacemaker is the only way on those patients who had a significant trauma or head injuries. What about orthostasis? Always manage it, involving rising slowly from a supine or sitting situation with a gradual change in posture. Always look for the medication that triggers orthostasis, typically diuretics and vasodilators, which can contribute to orthostasis. Now, compression stocking may be useful to improve the venous return, and intravenous fluid are really recommended who are really volume depleted. And again, midodrine might play a role and should be considered in refractory situation and cases. For the cardiac syncope, management is really directed to look for the underlying etiology. So you have to carefully diagnose your patient in order to help him. The options include anti-arrhythmic medications, cardiac pacing, catheter-directed ablation, and rarely you need to place an ICD. Now, this is the extremely important thing, is to risk stratify your patient. You need a criteria in order to admit your patient or to send him home and follow as an outpatient. So those patients who are at high risk that mandates hospital admission with a history of suggestive of arrhythmic syncope, you have to admit them to the hospital. Any patient who had comorbidities, you have to admit him to the hospital. Any EKG that suggests arrhythmias, you have to admit him to the hospital. Those patients with a family history of sudden cardiac death, you have to admit to the hospital. Those hypotensive, elderly, frail patients, you have to consider admitting to the hospital. Any patient with a structural heart disease, you know that severe aortic stenosis, HOCM, heart failure, coronary artery disease, you have to admit to the hospital. Those patients with a low risk typically are younger. They don't have any history of cardiovascular disease. Their EKG was fine. When you look carefully in the history and physical, you put your money on vasovagal or neurocardiogenic syncope, you're going to handle them easily in the emergency department and then send him home for further evaluation in an outpatient clinic. Those with unremarkable cardiovascular findings, usually you can send them to the hospital. For the most part, the most important is to differentiate situations where the patient had central reasons like seizures, metabolic reasons like hypoglycemia, it's extremely important. But the manifestations are typical with seizures. So you have to distinguish those patients with an aura, tonic-clonic activity, prolonged unconsciousness, urinary or bowel incontinence, tongue biting, confusion afterwards. These are typical manifestations of seizures. That's a different story. For the metabolic part, hypoglycemia is extremely important. If you are aware about the symptoms of hypoglycemia, whether hyperadrenergic status or neuroglycopenic, then you have to consider those patients having the syncope secondary to metabolic reasons. Now, the panic attack is typical. Complaint, feeling of impending doom, palpitation, air hunger, tingling sensation, perioral region, fingertips, hyperventilating. All these denotes to a panic attack that causes such a syncope. So always recognize these differences in order to get to your diagnosis. Now, for most syncopal episodes, as I mentioned, it's vasovagal and they are benign, typically in younger age. Syncope can be life-threatening, and it is associated with a cardiac disorder like rhythmic and valvular abnormalities. EKG is extremely important after you have a thorough history and physical exam. Following a syncopal episode, patient should be instructed not to drive or operate heavy machinery until the completion of their workup or follow-up. Mental illness, substance use, we've seen it a lot in patients with syncope who have no obvious or a clear etiology, so keep it in the back of your mind when you face such a situation. This is a 16-year-old boy present with a syncopal episode in which he lost consciousness during a football game. So هذا يعني almost بنسمعه كتير في عالم الرياضة. So you have to keep a certain differential in your mind. There was no history of a collision before the episode, no loss of bowel or bladder continence was noted. 1 year ago, same guy had a similar episode while participating in a marathon. What is the next step to determine the cause of syncope? If you have, the options, actually, remember these cases are life-threatening situation for those athlete people. Any recurrent syncope during activity in young patient always narrows the differential diagnosis. Things to consider, including structural heart disease like hypertrophic cardiomyopathy, AS, pulmonary hypertension, anomalous coronary arteries. We're talking about young people. ARVD or primary arrhythmias like long QT interval, catecholaminergic polymorphic VT, Progada. Remember that HOCM is the most common entity causing syncope in athlete and young people. So HOCM needs to be ruled out. Your first option is to do an echogram for those athlete people before patient may resume physical exercise in order to avoid sudden cardiac death. So echo helps confirming LVH, assessment of LVOT, assessment of ejection fraction, evaluating the right ventricle and any valvular pathology. It's another case where the elderly woman had no history of cardiovascular disease, had 2 syncopal episodes in 1 week. She has normal vital signs on physical exam. There is labs were okay, EKG was normal, echocardiogram was done, and it was normal. So the most appropriate to investigate as a cause of syncope, let me put you an options, MRI, carotid Doppler, external event monitoring, urine drug screen. So for an elderly with a normal vitals, normal physical findings, normal echo, normal ECG, and you know that this episode 2 syncope in 1 week, you have to consider event recorder. So a normal EKG in an absence of any structural heart disease is really associated with a good prognosis generally. An external event monitor is the most appropriate test to investigate syncope in this kind of patient. And the reason, because she had 2 episodes in almost 1 week, so 1 or 2 week monitor would be very reasonable in this elderly lady. Neither carotid stenosis nor embolic events causes syncope. Remember, you need to get both carotids, very tight in order to have a syncope. Probably vertebrobasilar might lead to such a syncope, but the patient had normal finding, normal everything. So with that, I would like to conclude and leave the floor to Dr. Ali. He will tackle the syncope, I guess, in
Pediatrics.
In pediatric age group. Thanks for your attention.
Thank you.
Thank you very much, Dr. Islam. You made my life easy, really, and this is why I asked for only 10 minutes when you told me to give the talk, because I'll start from the point that you alluded to, that the younger the patient, the more benign is the syncope. So, and we're dealing with young patients. So, so that's why it's more benign than pathologic when we have syncope during pediatric age. Okay, so definitions have been talked about. Syncope is a transient loss of consciousness associated with an inability to maintain postural tone, followed by rapid and spontaneous recovery with the absence of clinical features specific for another form of transient loss of consciousness, such as epileptic seizure. Now, vasovagal syncope is synonymous to reflex syncope or neurocardiogenic syncope and is defined as it occurs with upright posture held more than 30 seconds or with emotional stress, pain, or medical setting, features of diaphoresis, warmth, nausea and pallor, associated with hypotension and relative bradycardia, followed by fatigue. Now, syncope is common with a cumulative incidence of 35% by age of 60, as Dr. Islam said. Vasovagal syncope is the most common cause of syncope in children. Syncope accounts for 1% of emergency pediatric room visits in comparison to 5 or 6% in adults. And syncope care is inefficient with inappropriate costly tests. Okay. My references are 3 main references in my talk. One is the Canadian guidelines to diagnose syncope in pediatrics, and one is Johns Hopkins guidelines, and one is the Italian guidelines. So I tried to collect from the 3 in my lecture. The common causes of transient loss of consciousness in children, as you can see, there are, vasovagal syncope for more than 2/3 of the causes, breath-holding spells around 6%, cardiac are less than 5%, and neurologic are less than 5%. Metabolic are very low, psychiatric is around 2%, and unknown cause, as always, is around 10 to 20%. So more than 25% of children have one attack of syncope during their lifetime. Commonest cause, as we said, is neurocardiogenic vasovagal syncope. This is just to stress in detail some of the neuro-mediated syncopes: neurocardiogenic, postural orthostatic, pure autonomic, multiple system atrophy, cardiovascular, arrhythmic, structural or vascular, non-cardiovascular, pseudo-syncope, epileptic or psychogenic. And what are the warning signs? Now we come to the most important thing during pediatrics, because most of the cases are benign. So we need really in history and exam to look for these warning signs. And syncope in exercise or during exercise is by far the most important thing to look for. Absence of a prodrome is very important. Now, if a patient comes and says that I feel blaring of vision or I feel a certain sound, and then every time I have syncope, this is and the syncope is short, of course, as we said, this is by far is much more benign than pathologic. Syncope on loud noise, fright, or emotional stress. Now, this is because one of the prolonged QT interval types is initiated by loud noise, which is type 2, I think. Syncope when supine or during sleep, because this might indicate epileptic or neurologic. Long attacks of syncope. Syncope, which is benign, is usually not more than 2-3 minutes, 5 minutes on the maximum. Remaining sleepy for a while after attacks. This is very important. Usually, benign syncopes, the patient will wake up right away and will be active. Okay? And family history of epilepsy, family history of sudden death less than 50 years, and in some cases they say 35 years of age. So these are the most important warning signs to say that this syncope. So syncope occurring with mid-exertion. Post-exertional syncope is mostly benign. Syncope associated with recent changes of position is benign. Syncope when supine suggests neurologic or psychologic causes. Syncope preceded by palpitation is also significant oftentimes. Now, all syncopes will be followed by feeling or associated later on by feeling of tachycardia. So in pediatrics, so the patient will come to say that I felt my heart beating quick, but that's not at the start of syncope, after the occurrence of syncope. So you have to, in your history, differentiate the two. ECG is the most important investigation to exclude bronch-QT interval and other things, ventricular hypertrophy, pre-excitation, heart blocks. But the yield of ECG, as we can see here, whereas the ECG is the most often ordered test in children with syncope, the data do not support its routine use. That is from the Canadian recommendation. The yield is very low. It's 1% only in pediatric age. The cost is significant. Now we are talking about criteria in Canada, but in our part of the world it's much cheaper. So probably if we do our own criteria, we might not agree with these. However, the cost is significant, and abnormal ECGs at the time of the acute event are often false positive, subject to misinterpretation. Therefore, that committee, the Canadian Cardiovascular Society and Canadian Pediatric Cardiology Association position statement, revealed that it should not be done routinely unless there is an indication for that. And the indications to do ECG, according to them, is history is not diagnostic of vasovagal syncope, no prodrome before syncope, mid-exertional, syncope triggered by a loud noise, family history of sudden death, the things that I talked about, abnormal cardiac exam, new medications with potential cardiac side effects. And these are the abnormalities in the ECG. Dr. Islam talked about them in details. Mainly long QT interval are the red light and Brugada syndrome or Brugada pattern, and polymorphic BVCs or tachycardia, third degree AV block. Cardiac red flags. This is very important. Palpitations preceded syncope. Multiple episodes of syncope within a short period. Exertional syncope. Emotional syncope. Syncope with chest pain. Sudden cardiac death in family members. And history of familial arrhythmias. These are cardiac red flags to investigate. What if simple ECG does not catch the arrhythmia? Exercise test is very important, as the same significance as mentioned by Dr. Islam. Now, external event monitors, but sometimes they wouldn't catch the arrhythmia, and implantable loop recorder, I mean, very rarely we go to, but we might need them in certain rare cases. Just few words about prolonged QT interval. We all know how to calculate the corrected QT because in pediatric age we don't use the absolute QT interval. We use the corrected QT by dividing the QT by the square root of the preceding RR interval. If you have a normal QTC and still you are convinced that there are arrhythmias, you have to investigate because sometimes QTC prolongation, as our colleagues, electrophysiologists know, might be prolonged in certain situations and not all the time. So variable QTC prolongation of the QTC interval. Specific genetic mutations, it's a channelopathy. If untreated, the mortality is 50% in 10 years. And there are The treatment is not our goal now. There are three main genetic abnormalities, bronchitis 1 and 2 and 3. The 1 and 2 might respond to beta blockers, and 3 does not respond to beta blockers and might need implanted cardiovascular defibrillator. These are the references, which are the Canadian and Johns Hopkins and Italian references. And this is a schema of all my talk and how to handle a case of syncope. And in conclusion, in children, most syncopes are benign, but rarely might have a life-threatening arrhythmia. The most important key is a clear and detailed history. A 12-lead ECG is the most important investigation, though not definitive if history is suggestive. Beware of syncope and exertion. Benign and serious causes of syncope can coexist, and beta blockers are the mainstay of treatment for long QT, with AICD required in a minority of patients. Thank you very much.
Thank you. All right, we're doing great on time. Questions will be for at the end. So I'll introduce our next speaker, who doesn't need any introduction, Dr. Muhannad Ababneh, rhythm disorders in setting of acute coronary syndrome. Dr. Muhannad is another amazing interventionist in the northern Jordan at King Abdullah's University Hospital.
Pointer.
الله يعطيكم العافية وشكرا على الاستضافة. هذه صورة لمستشفى الملك المؤسس في إربد، اللي ما بيعرفوش واللي بيعرفوا عشان نعطيه شوية رينيسانس هيك يتذكر الهيستوري. راح نحكي اليوم عن موضوع بيخصنا جميعا اللي هو الاريثمياز in acute coronary syndrome. How to recognize it, acute management and prevention. The objective of this topic will be why does it matter in acute coronary syndrome? We say always reperfusion, and why do we want to speak about arrhythmias? A little bit about how does it develops, the pathophysiology, predictors of mortality, which patients are at higher risk, then a fast review of the types of arrhythmias and how to manage them. While timely reperfusion is the central to the management of acute coronary syndrome, arrhythmic complications are the major determinant of early outcome and sudden cardiac death in these patients, if pre-hospital or in the post-hospital time. In the pre-hospital arrhythmia, you can find a lot of data about how many patients suffers pre-hospital sudden cardiac death in ACS. Dr. Natalia will speak about this later. But it's estimated that about 2% of all acute coronary syndrome, and when we say acute coronary syndrome, we mean the whole spectrum, from unstable angina to ST elevation MI. That's all involved in this topic. About 2% dies in the pre-hospital setting, and of all acute coronary syndrome fatal events, there's one fatal, about 25% dies from arrhythmias. The problem in the pre-hospital mortality is mostly the delayed reperfusion. The patients are late presented. They receive the definitive therapy and the reperfusion late or later than it's acquired. We don't have CPR accessibility, and there is no defibrillation access mostly in the pre-hospital time. How does the mechanism, a little bit about the pathophysiology, what's happening in acute ischemia? Why is there electrical instability? Mostly ischemia, that's in anginal patients, there's an alteration in the ion channel activity with change in the action potential duration. That means we have an area of ischemia with another action potential duration than the normal or healthy area. That's a potential for re-entry tachycardias, which Dr. Laith spoke about earlier. In case of injury and infarction, it's similar, but here we have area that becomes non-conductive. We have non-conductive tissue to conductive tissue. Always here, risk area for the conduction of or development of ventricular arrhythmias. In acute MI, we have an autonomic imbalance. That's very important because of anterior wall MI, anterior stenio, we see the patients have a sympathicus overstimulation, and they have a sympathicus overdrive. They comes mostly with higher heart rate, with other situation. Inferior MI related to the right coronary artery they're presented often with vagal symptoms. They are more the parasympathicus is overstimulated. Also electrolyte shifts and LV dysfunction in patients, mainly in those with pre-existing cardiac problem and now suffering from acute coronary syndrome will develop arrhythmias. How to evaluate patients with acute coronary syndrome for the risk of arrhythmias? We say always patients with acute coronary syndrome have to be on the monitor. We have to monitor them for arrhythmias the whole time. In case, which patients are prone to prone more to development of serious arrhythmias? The larger infarct size, the late from onset of symptoms meets persisting infarction or injury. In case of incomplete revascularization, the presence of a substrate for arrhythmia prior to the event, that's previous events, MIs in the history of patients, and patients with complicated MI. These patient groups are prone to more serious and more lethal arrhythmias in the hospital setting. For the classification or which arrhythmias are common in acute coronary syndrome, mainly we can say all of them. I think we can accept just the supraventricular reentry tachycardias. They are very rare in acute coronary syndrome, but every other arrhythmia what we think about can happen. Supraventricular arrhythmias, fibrillation and flutter, ventricular arrhythmias in all its type, and the bradyarrhythmias. When we speak about supraventricular arrhythmias, atrial fibrillation occurs in about 5 to 23% of hospitalized acute coronary syndrome patients. That's mostly transient, and occasionally atrial flutter can happen, mostly derived by the sympathicus overstimulation or injury of the AV node. Not to forget that these supraventricular activity can contribute to more ischemia, to heart failure and embolic complications, what makes the worst outcome for these patients who are developing atrial fibrillation in the setting of acute coronary syndrome. They have these additional factors for bad outcome. The management will go fast here. In the acute setting, we are targeting just rate control with beta blocker mostly. If unstable or hypotensive, we have to consider other mechanisms. Unstable patients will go for cardioversion, and we don't to forget the anticoagulation. That's Charles score guided, what Dr. Ayman spoke about earlier. And we want to minimize the triple therapy as possible. The actual recommendations going with for patients with atrial fibrillation, that's the triple therapy for maximum 1 month, and if high bleeding risk, also after 1 week, the triple therapy can be discontinued. And as definitive therapy in the case of atrial flutter that's persisting is the cavo-tricuspid isthmus ablation with help of our electrophysiology colleagues. When we speak about ventricular arrhythmias, that's the second part of the types of arrhythmias that can occur. We have very common, we see always in mostly every acute coronary syndrome or MI patients are premature ventricular contractions. We see accelerated idioventricular rhythm, that's what's good sign. Ventricular tachycardia, torsade de points attack, and the most lethal is the ventricular fibrillation that needs emergent management. The PVCs, I'll try to highlight this example. I tried to pick the images inside the slides. I hope it's clear enough. PVCs does not need any management. They are harmless. In patients with non-sustained VTAC, that's the upper ECG, but that doesn't work right here. That's a good sign. That's non-sustained VTAC resulting from sympathicus overstimulation. That we see this in anterior myocardial infarction. That's signs of ischemia. It can be also a sign of reperfusion. And the significance is just these patients are prone to develop more serious arrhythmias that need further treatment. Accelerated idioventricular rhythm, that is just wide complex escape rhythm. We see just the ventricle is originating from the ventricle, and as the rhythm is generated by the ventricle, mostly in the area that's actually reperfused. That means and by itself, it's a good sign if you have the accelerated ventricular rhythm. That means you are having a reperfusion area. Usually, it's benign and self-limiting, doesn't need any targeted therapy. VTAC, Dr. Laith spoke a lot about ventricular tachycardias. Now, just in the case of acute MI, it happens in about 6 to 10% of all acute MI patients are developing in the first 2 days ventricular tachycardias. It's mostly, as we mentioned earlier, re-entry around the ischemic or the scarred zone, occasionally triggered by other factors like an extrasystole or sympathicus overstimulation. It's regular wide QRS and has mostly monomorphic morphology. The most certain ECG finding for diagnosing VTAC is the AV dissociation. If you have this, if you can see the P waves running through, not dependent to that what happens in the ventricle, that is for sure ventricular tachycardia. We have an early VTAC that happens in the first hours after MI that's transient, and a late VTAC that's scar mediated that requires long-term prevention. When we say early and late, it's about 48 hours. As a VTAC after 48 hours are late VTAC, and that's scar mediated, they are going to come again and need definitive treatment. We have this ECG of a patient with ventricular tachycardia. And just short to the management, in unstable patients, immediate synchronized cardioversion regarding the ACLS protocol. We start if the blood pressure or pulseless tachycardia with CPR. If in stable patients, the first line therapy is IV amiodarone. Beta blocker in the case of acute coronary syndrome are also advised and depends on the patient's blood pressure. If the patient develops VTAC, primary or early VTAC, and the ejection fraction persists to be less than 35 after 40 days of acute event, these patients are going to need an ICD, implanted cardioverter defibrillator. Ablation for recurrent or for VTAC or electrical storm, and definitive treatment for patients with not resolving VTAC in acute setting, maybe also a mechanical circulatory support, what we spoke about today earlier, until achieving a definitive treatment or ablation therapy. Torsades points can also occur in acute coronary syndrome for the same reasons we spoke about previously. The changes in depolarization areas can also provoke QT prolongation or extrasystoles that can start the torsade ventricular tachycardia. In this case, just about the management, you see in the torsade points the shifting in the axis of the tachycardia, that is the spikes and the domes in the tachycardia are changing the axis around the baseline. We start in this case as we're giving our patients. If the patient is unconscious or hemodynamically unstable, we will defibrillate this patient. The patient mostly or very often we see the patients are stable in the initial phase, and this time is enough to give them 2 grams of the magnesium sulfate. That will mostly be enough to stop the ventricular tachycardia, stop any drugs that can prolong the QT time. And if patients, the torsade point developed in patients with bradycardia, you know, bradycardia, you have long diastolic time. There's enough time for extrasystoles that can cause or provoke torsade tachycardias. In this case, you can consider an overdrive pacing. I did this just once in my career till now, to keep the patients in a higher heart rate than they are, just to prevent the opportunity for this extrasystole that starts or that promotes the torsades. In VF, ventricular fibrillation or pulseless VTAC, that's a topic for the AHA-ACLS advanced cardiac life support. That happens also in about 5 to 10% in severe MI patients, depends on the population with severity of the infarction related to. It's multiple re-entry circuits. We spoke about, and simple VTAC is just one area that's definitive. In ventricular fibrillation, the whole heart is spinning around. That's chaotic depolarization resulting in cardiac either arrest or failure to output. Here, the prognosis of these patients depends on how fast you react. The earlier defibrillation and achieving a reperfusion, these patients will improve the prognosis significantly. We are counting here earlier with seconds and minutes, not with hours and days. Immediate CPR and according to CPR protocol. In patients with acute coronary syndrome, as this lecture to be mentioned, the actual recommendation after recovery or recovery of spontaneous circulation, patients with MI have to undergo urgent PCI. Just because the reperfusion is here the definitive treatment. So just to highlight that immediate treatment of ventricular fibrillation or pulseless ventricular tachycardia is in the pre-hospital setting and in the in-hospital setting, time-dependent. The European Society recommends also in patients where when you witness the ventricular fibrillation that happens, patient is in your ICU, you monitor him, you see the ventricular fibrillation, shock them first. We can make here the ACLS guidelines will say start CPR routinely, but if you witness it, start with a shock. The coronary reperfusion in these patients means heart muscle, heart failure prevention in the future and saving life for these patients. In the last 5 minutes of my session, I want to highlight some 2-3 slides about bradyarrhythmias and acute coronary syndrome. We see bradyarrhythmias very common in inferior myocardial infarction, that's mostly right coronary artery territory, and with involvement of sinus node or AV node. It's mostly defined by heart rate below 60, may cause also hypotension or syncope. In asymptomatic patients with bradycardia, just monitoring. If the patient is symptomatic, we will give here atropine IV every 3 to 5 minutes, maximum 3 milligram, because beyond this, it's not going to work anymore. You're just looking for the side effects. If it's refractory for treatment, the patient is symptomatic, they need to be on a pacemaker. In this case, temporary pacing. In the ECG below, you see a patient with a complete heart block. Just here for a better understanding for what we do and when, I have this slide from the internet about the blood supply of the electric conduction system. Just to see here, I hope it works now. As the sinus node is first 60% or 50 to 60% supplied by the right coronary artery. But what's important to see is that the AV node is in 90% of cases supplied by the right coronary artery. That means most or very often we have an AV node involvement in case of right coronary artery infarction. The His bundle and the bundle branches, the left and right bundle branches, are supplied by the left coronary artery and the left posterior and His bundle by the right coronary artery also, as the left posterior and His bundle have a double blood supply in most cases, and the rest is defined by single artery. What does this mean for this case scenario? Patient comes with inferior MI and complete heart block. His blood pressure, heart rate is 38, blood pressure is more than 150 to 60. He has his severe chest pain without S. Sweaty with mild dizziness. His main complaint is the chest pain. In this case, what to do? Reperfusion, there was monitoring only. This patient recovered spontaneously after the cath, I think so, 5 to 10 minutes. He was in complete recovery. Why do patients develop bradycardia or AV blocks in the setting? or we, just to skip this. AV blocks in the setting of bradycardia or in the setting of acute coronary syndrome. First degree AV block doesn't need any specific treatment. It's often in inferior MI where the AV node is involved. We just need observation. Type 1 Mobitz or Winkebach, that's what Dr. Basil mentioned earlier, that's mostly transient because it's also an involvement of the AV node itself that's transient. If the patient is symptomatic, they need atropine, or in some rare cases, temporary pacing. Type 2 Mobitz, that is the sudden non-conducted P waves with fixed PR. In the setting of ACS and in general, as Dr. Basil earlier mentioned, these patients need pacing. Because the problem here in these patients is the infrahessian problem that symbolizes or reflects a higher grade problem in the conduction system. In complete heart block, where we see an AV dissociation with an escape rhythm that can be wide or narrow. Here, in this case, if the patient is symptomatic, in the most cases, observation only is enough if the patient is asymptomatic and have no signs of hyperperfusion. Temporary pacing in this setting can be enough for, mostly in the case of inferior MI. So the comprehensive management of arrhythmias, we have preventive strategies. Patients with acute coronary syndrome have to be continuously on ECG monitoring, and in high-risk patients for the first 72 hours after myocardial infarction. Main contribution for prevention is the early reperfusion. Also, we aim to achieve complete reperfusion as early as possible, and the guideline-directed therapy of acute coronary syndrome. Immediate, if the patient is in fibrillation or pulseless VTAC, defibrillation, immediately medication for sustained VTAC or rate control in case of supraventricular arrhythmias. For long-term management, secondary prevention, as we said earlier, for more than after 40 days, if persisting ejection fraction reduction, the patients with arrhythmias will need an ICD. Optimization of the electrolytes of patients and antiarrhythmic therapy is routinely, we give beta blockers anyway in our coronary artery disease patients, and we avoid proarrhythmic drugs. What to take from this short review? Ventricular arrhythmias are the most lethal early arrhythmias in acute coronary syndrome. That means we have time critical management in this case. Early recognition and high quality CPR and defibrillation, and the rapid reperfusion that saves lives and prevents morbidity regarding heart failure in the future. Atrial fibrillation, bradyarrhythmias, PVCs, non-sustained VTACs require targeted therapy. There is no one-for-all recipe for these cases. Targeted therapy in certain cases. Mostly they are reversible. And in cases you have refractory arrhythmias after complete revascularization, engage electrophysiology early, and think always about long-term prevention. Optimal therapy for coronary artery disease and heart failure will prevent arrhythmias, beta blockers, and significant indication for ICD not to be forgotten.
Thank you.
These are the references, and thank you for listening.
Thank you, Dr. Muhannad. Please join us here on the panel. To keep the subject all together, actually, we're going to move ahead to Dr. Natalia AlShawabkeh, who's going to tell us about sudden cardiac death, special emphasis on sudden cardiac death in adolescents. I was lucky to actually also share the presentation on the recent Madrid European Society of Cardiology, the one we did about the chest pain care there, and me and Dr. Natalia presented the cases, and there was actually excellent feedback. So Dr. Natalia, we're looking forward for this lecture. Go ahead.
Thank you. Good evening, dear colleague. My talk will be about sudden cardiac death in competitive athletes. Among 2023, national coach Jamal Mahmoud called on the Ministry of Youth, Jordanian Olympic Committee, and Jordanian Football Association to take urgent action to develop a quick preventive plan before the start of the 2022 football season, after the sudden increase in the number of deaths among football players, the COSAI initiative launched by His Royal Highness Crown Prince Al Hussein bin Talal II in 2014 in memory of the Jordanian player COSAI Hawalda, who lost his life due to an unfortunate accident in a sports stadium. Recently, cases of heart disease affecting athletes have increased, from athletes who lose their life and others who retire. And victim of these injuries being Algerian player Sofiane Lokar, who died after falling in the field during a match between his team MC Saida and the Algerian ASN Oran team due to a heart attack. A TV broadcast of a match in the Omani League between Muscat Club and Suwayk Club was delayed due to tragic death of Muscat defender Muhannad al-Rakadi during the warm-up process due to severe heart attack. So, can we predict and prevent those tragic events? Significance and societal impact, causes of sudden cardiac death in young people, mechanism, screening strategies to prevent, treatment and intervention for sudden cardiac death causes. Generally, health perception is that younger people in age below 40 constitute the healthiest segment of the society, the youth in this pathology of the victims. Such deaths often assume a high public profile. Case presentation. Damar Hamlin, 24 years old athlete, no previous medical illness, sudden collapse during the game of January 2023, no pulse, CPR initiated in the field. Successfully, he had a return of spontaneous circulation and was transferred to the nearest hospital ICU. Causes of sudden cardiac death in United States athlete. Register shows that first cause is more frequent hypertrophic cardiomyopathy, second coronary artery anomalies, also intermediate left ventricular hypertrophy, possible cardiomyopathy, followed by arrhythmogenic right ventricular cardiomyopathy, myocarditis, mitral valve prolapse, tunneled LAD, coronary artery disease, aortic stenosis, dilated cardiomyopathy, sarcoidosis, aortic rupture, ion channelopathies, and other congenital heart disease, and others. Note that relatively benign condition like mitral valve prolapse and tunneled coronary artery bridging in competitive athlete may be cause of death. This is a different percentage in different registries. Comparison in Europe and ESA, in both schemes, the leading cause of death is hypertrophic cardiomyopathy. Common causes of sudden cardiac death in young athletes: structural cardiac anomalies, electrical anomalies, and acquired anomalies. Mechanism of death in the vast majority of these events is due to ventricular tachyarrhythmias, ventricular fibrillation, and ventricular tachycardia. Marfan syndrome and related disorders associated with aortic dilatation, sudden cardiac death usually occur because of aortic dissection and rupture. Hypertrophic cardiomyopathy, cause of death usually left ventricular outflow tract obstruction and possible arrhythmias. Other causes: heat stroke, cerebral aneurysm, bronchial asthma, sickle cell trait, nutritional supplement, illicit drugs. Case. The cause of sudden cardiac death in our case was commotio cordis, direct injury, trauma to the heart. This is a scheme of trauma. The ball affected chest wall in vulnerable period of time, ascending type upstroke of T wave. That's why happened ventricular fibrillation. Prevalence and scope of the problem. Sudden cardiac death in athletes is an infrequent event, and only a small proportion are in fact at risk. 0.3% in general athlete population. American Heart Association, American College of Cardiology screening guidelines. 14 element recommendation. First of all, personal history, chest pain, tiredness, pressure related to exertion, unexplained syncope, heat syncope, exercise and unexplained dyspnea, fatigue or palpitation, prior recognition of heart murmur, elevated blood pressure, prior restriction from participation in sport, prior testing for the heart ordered by physician, family history of premature sudden cardiac death below age of 50, or disability from heart disease in age below 50. History of hypertrophic or dilated cardiomyopathy, long QT syndrome, other channelopathies, Marfan syndrome, clinically significant arrhythmias, and specific knowledge of genetic cardiac condition and family members. Physical examination for estimation of heart murmur, femoral pulses, physical stigmata for Marfan syndrome. European guidelines, family history and personal history, physical examination, and 12 lead ECG for all participants. If normal, no contraindication for sport. If abnormal, further examination. Echocardiography, stress test, Holter monitoring, MRI, endomyocardial biopsy, electrophysiologic study, if needed. If normal, no contraindication. If abnormal, restrict participation in competitive sport. This is different pathology, different types of channelopathy and pre-excitation and hypertrophic cardiomyopathy, and corresponded type of arrhythmias. Type of arrhythmias, pathology, and electrophysiologic parameter. Abnormality in PR interval, QT interval. For example, long QT syndrome prolonged if more than 440 in male and 460 in female. So, dynamic left ventricular obstruction in hypertrophic cardiomyopathy. Previously controversial, but now widespread agreement that left ventricular outflow obstruction is a common and important cause of symptoms in hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is 1/3 each: resting obstruction, accessional obstruction, and non-obstructive. 70% of obstructive has gradient more than 30 millimeter hydrargyrum. Dynamic obstruction. Leaflets subjected to attack of war between drag forces outflow and the mitral valve tethers, factor contributing to left ventricular outflow tract obstruction. Loading conditions, increased contractility, elongated lefted anterior coaptation point, chordal slack, PAP anomaly. Pharmacological treatment algorithm. If there is obstruction, DC culprit medication, heart failure or anginal symptom estimated, go to beta blocker, verapamil, diazepamide. If no obstruction, treatment as non-obstructive hypertrophic cardiomyopathy. Another frequent cause of sudden cardiac death is coronary artery anomalies. Percentage 0.3, 1.6 incident. Chest pain or shortness of breath with accession, signs of heart failure, sudden syncope or death. Diagnosis, stress test, CT angiography, MRI, or angiography, and treatment is surgical. For example, Pete Maravich, Pistol Pete, was born with a single coronary artery arising from the right coronary sinus. Non-sportsman in basketball American League, sudden death at age of 40. This is a scheme of more frequent coronary artery anomalies. Anomalies may be divided in 3 categories: abnormal region, abnormal course, and abnormal structure. Abnormal region from contralateral sinus of Valsalva, course in front of pulmonary artery or behind. The most dangerous is between main vessels. This is more dangerous. Diagnosis and treatment. Stress testing can be useful. Coronary angiography, gold standard. CT angiography, MR angiography. Treatment is surgical. Wolff-Parkinson-White syndrome, pre-excitation. This is a ECG with Wolff-Parkinson-White syndrome with atrial fibrillation in 23-year-old man with episode of palpitation. Due to high velocity of electrical impulse through bypass tract, atrial fibrillation from atrial conducted to ventricle with very fast, unusually fast heart rate, sometimes more than 200, 220 per minute. Antiarrhythmics used for treatment of WPW syndrome, procainamide, flecainide, propafenone. Patient needs electrophysiologic study with possible ablation if accessory pathway refractoriness is less than 250 milliseconds or if symptoms. But sudden cardiac death is rare. Antiarrhythmic right ventricular arrhythmogenic right ventricular cardiomyopathy, autosomal dominant disease, predominantly affect right ventricular free wall, but also may be seen in septum and left ventricle. Genetical autosomal dominant inheritance. Antiarrhythmic medication, ablation, and ICD recommended in this pathology. Brugada syndrome, abnormal ECG finding in right precordial leads, V1, V2. There is 2 main types with saddle type and covert type of ST elevation. Patient have increased incidence of ventricular tachyarrhythmias. Quinidine may be decrease episode, but usually needed ICD. Long QT syndrome. 3 main type. First and second correspond to potassium current channels, and third one to sodium. Different ECG picture in first, second, and third, and trigger are also different. If first type, usually on excision, patient may develop ventricular tachyarrhythmias. In second, mostly emotional stress. And third type, mostly at rest, even during night. QT interval should be less than 47 in males and less than 480 in females. This is different ECGs in different type of long QT syndrome. Type 1, induced tachyarrhythmias by stress exercise, especially swimming. Type 2, stress, even alarm clock may induce tachyarrhythmias. Reb Voro has been hailed a brilliant cyclist after his death. His death happened at night during sleep, suspected channelopathy. Once again, long QT syndrome with different type. Treatment, beta blockers in first and second type, mexiletine in type 3, and automated implantate cardioverter defibrillator. Catecholamine energic polymorphic ventricular tachycardia. Treatment, beta blockers, flecainide, and ICD implantation. This type of arrhythmia induced by catecholaminergic stimulation. This tachycardia induced by electrophysiologics during electrophysiologic study, and right bidirectional tachycardia on treadmill. Treatment, beta blockers, nadolol, flecainide may be useful, and ICD controversial. Myocarditis, different bacteria and viruses may induce myocarditis with subsequent tachyarrhythmias and heart failure. Recommendation for evaluation of sudden cardiac arrest survival, according to European Society of Cardiology. Survivor without obvious extracardiac cause recommended to be overseen by multidisciplinary team. If cardiologically free, you can go to brain CT, chest CT. Also, collection of blood sample recommended for diagnosis of potential toxicology and genetic testing. A retrieval of recording from cardiac implantate electrolink devices and wearable monitors is recommended for all sudden cardiac arrest survivors. Repeated 12-lead ECG during stable rhythm, including high precordial lead ECG to rule out Brugada syndrome, as well as continuous cardiac monitoring are recommended. Echocardiography, coronary imaging with CMR with late gadolinium enhancement are recommended for evaluation of cardiac structure and function in all cardiac arrest survivors without clear underlying cause. Sodium channel blocker test and exercise testing is recommended in sudden cardiac arrest survivors without clear underlying cause.
Dr. Natalia, your 30 seconds over.
Okay. Recreational exercise recommendation. Athletes with probable or unequivocal clinical expression and diagnosis of hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, CPVT, long QT should not participate in most competitive sport. Not for them. Not for them, stop. Be thorough. Have a high index of suspicion. Realize that you are looking for a needle in a haystack, but if find this needle, it's huge. Let me remind this percentage. Even in your outpatient clinic, with just 12 lead ECG and echocardiography, you can estimate more than 50% of potential pathology. And if you go to stress test, Holter monitor, and coronary CT angiography, you can estimate more than 80% of possible pathology, treat and prevent sudden death. And thank you.
Thank you. All right, so last speech for the day, but not the least, Dr. Mohammed Al-Hajjiri, Atrial Fibrillation, the Jordanian Task Force Guideline.
Thank you very much, Dr. Natalia. That was excellent. Thank you all for these great speeches. All right, so I'm going to end with the guidelines for atrial fibrillation. So this is a joint effort. A huge thank you to my residents who helped put this, Dr. Khalid and Dr. Noor. So we're going to talk about the Jordanian Atrial Fibrillation Management Guidelines. So they're adopted from the American and the European guidelines. Next. How do I control this? Okay, so a little bit of background. We're not going to dwell too much on this because we all know why we're doing this. Same thing with the framework. There's a reason why we make this. This has to be based on populations and what's helpful. Okay, atrial fibrillation. It's a tachyarrhythmia and coordinated atrial activity. I think anybody could, any doctor, medical student will be able to diagnose atrial fibrillation. So diagnosis, 12-lead EKG, a Holter monitor, simple things for the non-cardiologists with us and for the medical students. You have to see the atrial fibrillation with your own eyes. Oftentimes, I'm told somebody has atrial fibrillation and they're stuck with this with diagnosis. And actually, it happened in the US where somebody, from 5 years ago, somebody said that they saw AFib and it comes from one person to another to another. Make sure that you actually see atrial fibrillation before you actually give that diagnosis, because that person is stuck with that diagnosis. Risk stratification, and my colleagues have already spoken about this. Risk stratifying with CHADS-VASc scoring system. This is for the stroke, because we probably all know that atrial fibrillation, one of the worst things that it can do is that it can cause strokes. So just make sure that every patient you have is stratified for stroke. Also stratified for bleeding, as one of my colleagues will also touched up on this. It's very important to make sure that certain patients, this doesn't really apply on some certain patients. Certain patients, if you have, for example, AFib and HOCM, you have to anticoagulate. AFib in patients with thyrotoxicosis, you also have to anticoagulate. But this is very important for everybody else. All right, so stroke and bleeding risk stratification should be done annually. This is a class 1 recommendation. Anticoagulation, class 1 recommendation with the DOACs, or NOACs, novel anticoagulants. And Dr. Raed has already touched up on one of them. Anticoagulation is also recommended indefinitely unless contraindicated or unless left atrial appendage occlusion device is successfully performed. We're going to go over this. We have certain Jordan-specific notes, because certain things in Jordan that's probably not available in different countries. One thing is that apixaban, dabigatran, and rivaroxaban, they're available. Edoxaban is not available in Jordan. Apixaban is available in local formulations. I guess today we learned about one of those formulations. It's important also, apixaban was not associated with increased GI bleeding, contrast with dabigatran. And the same thing, there are studies for edoxaban, rivaroxaban. But as I mentioned, in Jordan, we do not have edoxaban. More special recommendations, CHADS-VAScs. We all know about this, ECG features. Some of the things that's important for general doctors, cardiologists, obviously, we already do that, but general doctors, ER doctors, is to take a look at the atrial enlargement and AF burden, because that's also helpful. And it's helpful for me as an electrophysiologist, because if I see somebody with a huge left atrium, then that person is probably not going to benefit much from an ablation. Or we tell that patient that you're probably going to need more than one ablation. Left atrial appendage occlusion devices, they should be considered for patients who are intolerant or have contraindications to anticoagulation. That's also all right. So anticoagulation algorithm, risk stratification with the CHADS-FASC, the scores. This is something we already probably all of us know about. If you're undergoing surgery, certain things we're going to do. Of course, these guidelines, we are going to print them and we're going to distribute them. That's the plan with Dr. Jamal. This is probably going to go to all these to all the ERs. That's not just in Amman, all over the country that will help out with this. It's important to note that if you have moderate or severe mitral stenosis, usually you prefer with warfarin as opposed to the DOACs. This is a little bit more information about apixaban and when to use the 2.5 milligrams POBID, which Dr. Raed has already gone over. And for the interest of time, I know it's the end of the day and everybody's tired, half the people are sleeping. So in Jordan also, acute rate control, beta blockers and calcium channel blockers, diltiazem and verapamil. All right, so we do not have IV diltiazem in Jordan. And this is the biggest shock of my life, because we use this so much for rate control. I'm not so sure. My session is the last one, so we're going to have questions right after that. And I would like to get people's input on what they use for rate control. I personally started using esmolol in the hospital if I need to rate control somebody because the diltiazem is not available. As we know, we don't like diltiazem in somebody with low ejection fraction. Amiodarone, I have this love-hate relationship with amiodarone. A lot of people who work with me know how much I hate prescribing amio, but sometimes it's like a pact with the devil. Sometimes you have to use it, and it is a useful drug. Acute rate control algorithm. This is basically what I just said. The hemodynamically unstable, you want to shock the patient. If they're stable, you can wait and rate control. Personally, I always like to put the patient back in sinus rhythm, and this is something that I do not like the patient to be committed to a diagnosis of AFib for the rest of their lives. Generally, if somebody, even if they come with the first, it's something that I see a lot in some of the practice where patients come with AFib and they're like, oh, it's okay, don't worry about it, you can live with AFib for the rest of your life. And this is not something I would probably agree with, because this, you can shock them, you can get them out of it, and the updated guidelines, as we're going to talk about, it's no longer recommended, like the AFFIRM trial that we learned when we were medical students or when we were internal medicine residents is no longer relevant. This is the algorithm that I'm not going to bore you, go over it in detail, because this is something I'm already talking about it. Okay, some of the common things in Jordan, as these are the guidelines for pertinent to Jordan. Beta blockers, bisoprolol, metoprolol succinate, and propranolol are available. In addition to nebivolol is available, but there is no metoprolol tartrate, which is the short-acting metoprolol. Diltiazem, we have it, but then there are shortages that unfortunately we don't always have diltiazem. Diltiazem comes in a 90 milligrams and a 60 milligrams BID, which also it's a little different from the guideline, or from what those of us who've worked in the US, we usually started with 120 diltiazem XL, which is not available here. But for us, these medications, we can use them. We can use the diltiazem PO. As I said, it is not available in an IV. Target heart rate, lenient, is less than 110 and is based on an older trial, RACE 2 trial, that there's no difference between rate control if you're tight or not. Long-term rate control algorithm, and this is, it pains me to talk about rate control, as you guys know that I'm more of a rhythm control kind of a person. But since if we're going like that, there's also different algorithms that we could use. Beta blockers are still the mainstay. Beta blockers are helpful. And as I mentioned, some of those beta blockers that are available in Jordan. Remember, if the ejection fraction is low and you have to use the beta blockers, always use the heart failure beta blockers, which are metoprolol succinate, which we have in Jordan. Carvedilol and bisoprolol are helpful in patients with low heart rate, and that's with low ejection fraction. Digoxin is also available. We do not have digitoxin or digitalis, which I think in a the recent article that there was actually a difference between the two, and digitalis has actually more helpful in heart failure. There's a recent article, and it's used more in Europe. We have digoxin. Rhythm control. Rhythm control, pharmacological in Jordan. Amio remains widely used in Jordan. In some cases, it is given in acute rhythm control in patients without or prior TEE to rule out left atrial appendage. And this is a description of the practice. It is not a recommendation. This is one of the things that we see quite often is that, let me give you an example. A patient comes in, and this is something we see very frequently. A 60-year-old who comes with a heart rate of 180, for example, and the patient is in AFib. The patient is instantly given amiodarone IV. And this is something that we see all the time, instantly. Amiodarone IV starts with enoxaparin or Clexane. And we cannot always rely on the patient's history just because the patient said, I just felt it. Well, she just felt the RVR, but doesn't mean that the AFib started when the patient felt it. So it's quite often, and we do catch a lot of those, a lot of clots in the left atrial appendage for patients who claim that it's been less than 48 hours. Generally speaking, we have to be very careful first of all, some of our patients are very poor historians, and we have to be very careful is that if we give amiodarone from the beginning with the Clexane, then it's not enough Clexane for the patient, and they may go back in sinus rhythm, and they may have a clot, and that clot will go to the brain, and it will cause a stroke. And this is something we have to be very careful about. Strokes can be caused like that. If you give amio, you're basically chemically converting the patient into sinus rhythm. So we have to be very careful on when the AFib started, when to give amio. If we're absolutely certain, that's fine because that's chemical cardioversion. Otherwise, a TEE should be done. Flecainide, we had issues finding flecainide in Jordan. I'm happy that we finally have it in the private practice. Historically, they've had it in the Royal Medical Services, and I used to send my patients to Royal Medical Services just to get the flecainide. Sometimes some patients may have difficulties finding that. But now it is available. We have certain medications. We don't have dofetilide, just Ticasine. We don't have sotalol. Sotalol, we have to bring it from Turkey, from Iraq. So these are some of the medications that we are used to prescribing outside of Jordan, but they are not available in Jordan. Let's go to the next. Electrical cardioversion, class 1 recommendation. As I said, I do not recommend keeping patients in AFib. Try to get them out of AFib before remodeling happens in the left atrium. Pharmacological cardioversion, we just touched up on it with amio or something else. Ablation. Ablation is now a class 1 recommendation in many situations. So symptomatic AF patients refractory intolerant to antiarrhythmics, patients with AF and HFrEF, this has been proven with multiple trials. There's 2 papers actually that were published in New England Journal of Medicine by Dr. Marrouche that showed even in advanced heart failure, even with patients with ejection fractions in the 15 and 20%, in advanced heart failure, even with large left atrium, the patients will benefit from AFib ablation. So this is something very, very important. And this is a major change in the practice because historically, patients, we learned, as I touched up on the AFFIRM trial, is that when we were medical students or residents, we learned about that there's no difference between rhythm control and rate control. And this is no longer relevant because the technology in 2003 this was not available. The technology was not as good as now, and the ablations were not as well done as they are right now. All right, AF ablations obviously should be performed in specialized center with expertise, because anybody who does AF ablations, they know that things can go, rarely, but they can go badly. So we have to make sure that the center is a tertiary center that can help the patient in case something goes badly. PFAs, this is the new highly selective catheter ablation method, and this is basically, it's a new way ablation, but those of us who do ablations know that there are PV stenosis, and sometimes there are esophageal fistulae that can happen from historically RF ablations. So this basically came to solve that. All right, so different ablation technologies that I guess I only have 5 more minutes, so we can touch up on this later. This is the PFA. Basically, it uses pulse field technology, different percentages of ablation procedures. These are the 2023 updated guidelines. So catheter ablation receives a class 1 indication as first-line therapy in selected patients. And catheter ablations are performed in Jordan successfully, and we have PFAs in the private sector and in the public sector, so there's no reason why we cannot adopt this practice that helps patients and that hopefully changes the practice in Jordan to those that is on par with the rest of the world. Early rhythm control is very important. Catheter ablation of AF is appropriate in patients with heart failure. As I said, this is a class 1 indication. If you have heart failure and patients, one of the things our job also to try to spread more awareness about AF is that when you have patients who have coronary artery disease, for example, it's not that small PLV that's closed. That opening that small PLV is not going to improve that 20% ejection fraction in a patient who has persistent AF. So it's one of the things that sometimes we see in practice. This is some of the 3D assisted ablations. This is a left atrial appendage, the red. How do you highlight, by the way? How do you highlight?
Just keep pressing.
The hold?
Yes.
Okay. There you go. This is a video, so you can't highlight the video. Okay. It used to be a video, it's not working, but the red is basically scar tissue. This is a left atrium. The red is scar tissue. The purple is healthy tissue. And you basically don't want your left atrium to look like this. You don't want your left atrium to look all scarry and all red. And if you leave patients in atrial fibrillation, this is basically what's going to happen to your left atrium. And this is basically what happens to a lot of patients who are left on antiarrhythmics or on beta blockers and just going through the rate control route. And we don't want to do this because the more scar you have, the harder it is to get rid of the atrial fibrillation. Let me see how. Okay, this is a healthier left atrium. As you can see, this is all purple. So this is how a healthy left atrium should generally look like. Okay, this is, I know for sure this is a video. Can you play it? تقدر تشغلها؟ Okay. That's fine. I wanted to show you a 4-hour ablation in 3 seconds. Okay, this is valvular AFib. So this is a patient of mine who has had a severe mitral stenosis and MVRs, and this is basically how her left atrium looked like on the posterior wall, which we cannot see from here because I guess the technical glitch. The posterior wall is also all scarry. This is a lot of scar. This is a very sick left atrium. This is actually the right atrium in somebody who's had, this is actually the same patient. On her right side, the posterior wall of the right atrium is also completely scarred. And I think we ran out of time. We only have one more minute. This is a simplified algorithm. As I said, this is all going to be published, and it's going to be printed and sent out to all the different ERs and all different medical centers to help them with a simplistic approach to how to go over all of this. So summary, we do have anticoagulation. Thankfully, we have all the important ones. Some of them are not available. Rate control is mostly done by beta blockers. Sometimes it's done by amio for rate control. I don't like it. I just don't really agree with it. There is a diltiazem shortage. Diltiazem IV is not available. And the digoxin, it's fine. We can use the digoxin with a limited role. Rhythm control, amio is still dominant with rhythm control. Flecainide, we have it. Make sure you do not use flecainide with a low ejection fraction. We do not use flecainide with coronary artery disease, although in Europe, if you have stable CAD, they still use flecainide. Flecainide and propafenone are interchangeable. Several recommended drugs not available. Ablation is expanding role, especially in HFrEF. Thank you very much. All right, and it's the end of the day, so we're going to have questions right now. I did prepare some questions for all the panelists, and Dr. Qais, do you want to start?
Yeah, I had a question actually. I want to kind of highlight, because we have a lot of students with us also. You know, the key point, I agree with you. You know, there's a saying, probably you know it, AFib begets AFib. So the earlier you control,
yes,
the better it's for your patient. But as you said, the class 1 indication was for selected patients. So if we want to kind of highlight those selected patients, we're talking about younger patients, correct? With smaller left atriums, not hugely dilated left atriums, and maybe patients who are not responding to medications, they're still symptomatic despite, you know, trying to control them. Those are patients who cannot achieve any sort of rate control and also or have some degree of heart failure, and we're suspecting that heart failure to be due to AFib. Those are the selected patients.
Not really, no. It's a class 1 indication for patients. If you're symptomatic, for example, and you come to me in AFib and it recurred and you gave you beta blocker, it's still a class 1 indication to do it. So it is not the same person who has a heart failure patient who has not responded to the AADs. So right with the updated guidelines, you can do patient with paroxysmal AF. For example, I give you beta blocker, I give you flecainide, it's not working, I can do an ablation. So this is where in the routing, rate control is no longer recommended. I'm sorry.
Even if you are a 70-year-old gentleman with a left atrium of 5.5?
No. So that's what I mean. You have to use your clinical judgment. So if somebody's left atrium is 5.5 or 6, they're not going to be in a paroxysmal AFib. So they're most likely they are going to be in a persistent state because their atrium is huge. But yeah, you never know. But it's however, if you come to me, if you're 70 and you still have symptomatic AFib and you have palpitations and you have failed medication, then it is the right thing to do the ablation before your left atrium reaches the 5.5, because once it does reach the 5.5,
of course,
you're just going to go down.
Those are the younger patients. You want to catch it before.
You're going to go down. You're not going to get any better.
Thanks.
All right. So I have a few questions. I'm going to ask the honorable panelists a few questions of mine, and then if anybody has questions, please also share with us. So, Dr. Islam, you talked to us. Thank you very much for the syncope you talked about. One of the things is, what is, from your practice, implantable loop recorders? Now, one of the things that we used to use a lot in the US is just, we do an implantable loop recorder. As you know, you can implant it in 12 seconds or 10 seconds, very, very easily. But what is your experience in patients that you see who you think might need an ILR, but unfortunately, as we know, the expense in Jordan for that is very high, and also insurance companies don't cover it?
Well, thanks for the question, Dr. Muhammad. definitely the only barrier is the cost, to be honest with you, for ILRs. يعني احنا we don't like انه to have a burden. مشكلتنا حتى even the insurance companies, most of them actually they don't recognize ILRs for patients who had, scattered arrhythmias every now and then. But I just mentioned, even the event recorder, we don't have it available in the market here.
Yeah,
Probably
actually
in the
that's true.
office,
We don't.
we don't have even the event recorder. So the only way is just to have a Holter monitor for like a couple weeks, and that's what we rely on. Or we need to send, those patients to, our colleagues from the electrophysiologists that can handle those palpitations that we don't catch them even in the Holter monitor. Yes. So the barrier is financial, and we don't have the insurance companies recognize these, unique techniques.
Yeah. Any questions for Dr. Islam about syncope? Yes, Dr. Abdali.
We know that syncope is sometimes difficult to diagnose. My question is about the table test that you share the answer. When you advise patients doing the table test?
That's a very good question. Yes, do you want to answer?
It's your call. You are the electrophysiologist.
Tilt-table test. Okay, so
Personally, I don't do tilt-table tests in my office or in my...
tilt-table tests. I usually do them to confirm that somebody has vasovagal, to diagnose spots. Most of the time, the story is very benign, and it looks benign, and I think it's vasovagal, but I need to confirm it because I think it's our cultural thing also. Like, the patients are like, oh, you tell them it's most likely fine, and the patient doesn't like the word most likely. Like, so what is it? What is it? So basically, in these patients, I do the tilt-table test. POTS is very common, as you guys know. I'm sure you all see patients with POTS. But I don't do much of the tilt-table. I don't do that many tilt-table tests, but with patients, younger patient, had syncope, it looks like vasovagal, I want to reassure her, then we do the tilt-table test. She syncopizes on that tilt-table test, and I'm like, oh, well, the patient, you have tilt-table test. Sometimes in older patients, however, it is important to say that pauses in elderly patients, not the same as somebody who comes in at 60 years old and she has a 12-second pause, or in her 50s. It's no longer, we don't say vasovagal, we have to be very suspicious about sick sinus syndrome. So this is something that's important. Sometimes I have a patient who was in her 40s where she kept syncopizing all the time. She syncopized when she was driving her car. So it is vasovagal, but the circumstance is becoming dangerous. We know she's not going to die from her pauses because of the heart stopping, but she's going to die because one day she's going to drive into someone or she's going to kill someone. So this patient, I actually implanted the pacemaker, and she has not had syncope for many years now. She's actually one of my first Jordanian patients who came to me to Cleveland, and I ended up doing that when I was back in the US.
يعطيك العافية دكتور محمد.
Allah يعافي.
Sorry. When you decide to give midodrine for your patients with frequent...
Personally, I do that when they fail lifestyle modification. I tell them to drink shanine. If I know for sure that their blood pressure is dropping, not basically just the pauses, I tell them lifestyle modification. If they fail, then I give them midodrine. Midodrine is not available in Jordan. It's not available in Jordan. So,
the only solution here in Jordan is blood
beta blocker.
yes. Yes, Florinef is only available also. It's available in King Hussein Cancer Center. It's available also in مركز السكري. But midodrine is not available. So they have to bring it from Egypt. And in Egypt, they have tiny dose, 2.5 milligrams. So they have to bring tons of boxes there.
Thank you.
Dr. Muhammad, can I just regarding table test to return table test? How frequent is the false positive and false negative, especially in pediatric patients? Because
I'm sorry, can you repeat because it's not working.
False positives and false negatives.
Yes.
Especially in pediatric patients. Now, to justify doing anything, it's a cost really. And when we are dealing with patients that we see that it's mostly, as you said, vasovagal with the history and everything. So to justify do it, in the past I used to order it frequently. I used to do it when I was in training. But nowadays, sometimes I cannot justify doing it really because of the false negatives and the false positives. So what's your opinion about that?
I mean, it's an older test. I mean, it has its, but it is helpful, I think, in patients when you already know or almost think that these patients have vasovagal syncope, and it helps with confirming it. But what is the actual percentage for its false positive and false negative? It basically stimulates your vagus. So if your vagus is if it's basically hypersensitive, you're going to pass out. But again, also, it's you're provoking, if you do it in a middle-aged woman, middle-aged man, something like that, then sometimes you're provoking things you're not supposed to.
You still, Muhammad, have the, Muhammad here, you still for tilt-table test, you differentiate vasodepressive and cardioinhibitory.
I think that's
and according to this, you tailor your management?
Yes. I think that's another dimension for the test, is to
differentiate where to go.
Yeah. All right. So Dr. Laith was saying it's very specific, but not very sensitive. So if you lose consciousness, that's fine. But if you're doing it to screen for that, it may not be very helpful. Okay. So moving on just from the syncope part, we are... Oh. Dr. Ali, I had a question for you, because you talked about syncope in children, you talked about beta blockers. And which beta blockers do you use if you feel patients have long QT? If you diagnose somebody with long QT, and which beta blockers do you use in Jordan that's available?
Well, the available thing is the Concor, really, that we use.
Okay.
Yeah.
For like pediatric population. Yeah. Anyone wants to, any questions for Dr. Halabi? I think everybody here is like an adult cardiologist. Tomorrow is the...
But I thought that this will enlighten, because sometimes they might get pediatric patients.
Yes.
It's important to screen who is important to refer and who is not.
Absolutely.
A cold
yes.
case.
Absolutely. Personally, I don't see any pediatric population, but so more in the adult. In the adult population, usually the beta blockers we use are propranolol and nadolol, but with higher doses, 1 milligram per kilogram for the nadolol, and propranolol also must be a higher dose, like 120 milligrams PO for long QT. But for pediatric population, it's probably a different one. Dr. Ababneh, I have a question for you. You spoke to us about ACS and VT. It's quite an important topic. Now, if you have somebody, and this is something that it's actual patient that I have seen. If you have a patient who is, let's say, 55-year-old patient, your typical Jordanian smoker, big belly, and diabetes and all of that, and ejection fraction is 40%, and this patient has 5 stents and has a cabbage and 5 stents and a stent over the cabbage, the ejection fraction is 40%, and he comes to you with syncope. And we talked about VT, but usually what would you do?
Immediately, the first thing we do is the ECG and looking up for any development of his ground disease. And in these patients, we do routinely a Holter monitoring to find out what's happening there.
Yeah, that's the other thing. It's one of, I think, one of the restraints that we have in Jordan is the Holter monitor. It's only available in certain places for 48 hours. In Irbid, do you have the 2-week patch that we use in Amman?
We have ordered it for the next 2 months.
Okay.
We'll get it, but now we have this for 48 hours. We repeat it routinely for 2-3 times sometimes.
Yeah.
So we have cumulative 6 or 7 observation days.
But you can get it. I mean, because I know I was in Irbid, and I put for some patients, the private companies, they will provide it.
Yes, but in Amman, but in Irbid,
the companies in Amman can go to Irbid.
They will come to Irbid to...
Oh, they will?
Okay.
What would I do? I mean, I would refer him definitely for an EP study.
EP study is important.
Once we have, a structural heart disease, a low ejection fraction, and your money is in arrhythmias, you have to send this patient, actually, if he had a syncope, for an EP study.
VT is
maybe after ruling the most important things like hypotension, side effect of the medications, and the simple things, because not every patient you will send to EP because it's very costly, isn't it?
Yeah, we are an expensive
I
specialty.
know. Especially to you, Muhammad.
A little expensive. All right. Any questions for Dr. Ababneh? Any comments from my EP colleagues in the room? Yes, Laith.
Can I have a comment just
Yeah,
on Dr.
absolutely.
Natalia? Sorry. Tomorrow at 2, we're having a talk by Dr. Abdel Fattah about anomalous aortic origin of coronary artery and sudden death. So I would recommend everybody to
Attend.
That's actually that's very
attend,
important.
and because it will have more details on coronary artery anomalies and sudden death. Please.
And Dr. Abdel Fattah, is he?
He left. He just left.
He's coming. Okay. Yeah, so I think we should. I have a question for him because I get this all the time. Incidental findings, incidental-omas.
Maybe I can highlight some point I discussed with Dr. Basil before my session.
Yeah.
That's patients with inferior MI and anterior MI developing heart block. The discussion is in which patients we were going to wait for spontaneous resolution of this heart block and when not.
That's very important.
We went back to the
Yeah.
guidelines. It's clear in patients with inferior MI, as I described previously.
Yes.
That's mostly a reversible cause or a reversible ischemia of the AV node, and that's provoked by the parasympathicus overstimulation in the bradycardia. They resolve spontaneously, and the guidelines recommend to wait at least for 5 days, the European guidelines, before you decide for permanent pacemaker implantation. In the other side, the anterior wall MI, complicated by heart block, here's the guidelines recommend implant a pacemaker permanently as soon as the patient is stable, and not to exceed the 3 days.
Yeah.
Yeah. Dr. Basil, do you want to comment?
Probably the reasoning you're asking why do we wait for inferior MI, and because in anterior MI the damage is below the AV node. It's to the Hesperkingi system in LAD MI, but in inferior MI the damage is mainly to the AV node. That's one, and high vagal tone. Plus there is a dual AV nodal supply. So if the LAD, the AV nodal artery comes from the inferior, from the RCA, and also a branch from the LAD. So if the LAD is gone, the whole Purkinje system is gone. If the inferior MI, it's more like you say, sympathetic tone, and we have to wait, and the chance of recovery is high.
So it needs a huge amount of destruction to cause a heart block in anterior myocardial infarction.
There is what?
The destruction is growing, it's large in the setting of anterior MI.
It's infrahessian. It
Yes.
damages the Hesperkinge system.
Basil, still keep the microphone with you to ask you a more difficult question. For structural heart disease, when we implant TAVI, when we have left bundle branch block, it is more benign. When we have right bundle branch block, it is more malignant. And the need for pacemaker is higher when you have right bundle branch block instead of left bundle. Why?
The need again, can you say it again? When we have a right bundle branch block, the need for pacemaker is higher?
Yes, when we implant TAVI, we have right bundle branch, the likelihood of needing pacemaker is higher. And we consider it one of the malignant signs actually that we will need perioperative pacemaker after TAVI, while when you have left bundle branch block, you are not that afraid. And it may be even if the patient develop left bundle branch block after TAVI implantation, we wait for 24 hours maybe, but for right bundle branch block, no, it is not. We go for pacemaker. Why?
Maybe because of the anatomy, when you deploy the valve, it's just
low-seated valve, yeah.
Yeah.
When we block the left bundle, it is not.
It's
right bundle.
expected to almost block the left bundle.
Yeah.
But
It
if you
is
block the
closer.
right,
The left bundle is closer, so it might get a bit of compression and with the associated edema, so it's expected. But if you get the right bundle, that means it's too much compression and probably the need for a permanent pacemaker becomes higher.
Yeah,
It's the anatomy, basically.
May I interfere? Although it's not, it doesn't have anything to do with adult cardiology, but from the experience in perimembranous VSD closure, Because in the beginning of 2000, I was one of the early people who started transcatheter closure of perimetral VSDs. And we had high incidence of complete heart block because of the anatomy. And it was mainly right bundle branch block. Okay, so the valve is extending down, and it's causing, if it is causing real pressure on the right bundle, then it will cause a permanent damage rather than a temporary damage. Probably that might came to my mind, that might be an explanation.
Yeah, the same concept with RCA infarct.
Yeah.
The damage is mainly because of edema around the AV node. But in the LAD infarct, it's the damage to the Hesperkingi system. But I have a question to Dr. Raed, steering the gears now. What is higher bleeding risk, apixaban or dual antiplatelets? What has a higher bleeding risk? Dual antiplatelets or apixaban?
I refer this question to Muhammad. Hajjiri.
I mean, when we implant Watchman, we stop the apixaban and we put them on dual antiplatelets.
For 6 months?
For 40 days for the flex. Then one antiplatelet afterwards.
Yeah.
But, I mean, aspirin can have bleeding, sometimes comparable to apixaban.
Yeah.
But basically, I think it's also variable where the bleed, exactly, whether it's GI bleed. So aspirin is more notorious for GI bleeds, whereas Eliquis is
still.
This rule of thumb, I mean, NOACs or DOACs
are worse. Yes.
Yes.
You cannot do an open heart surgery on a DOAC.
Correct.
You can do an open heart surgery on aspirin, and even for emergency cases, we take patients on plasma for emergency, and they succeed, and actually we don't have that problem. So definitely DOACs are higher risk of bleeding compared to the
dual.
There's actually.
What's your opinion, Basil?
I'm not talking about GI bleeding secondary to aspirin, but definitely DOACs are way higher the risk of bleeding compared to that.
And that's why we implant Watchman, right? That's why we close the left atrial appendage so that we would stop the Eliquis, and we put them on platelets. However, it's important to note that antiplatelets are they're also not this benign drug. But I see your point. Yes, I agree with you.
All right, thank you.
Dr. Laith, yes.
Muhammad, sorry, Dr. Laith.
We run out of time. اوكي
بس بدي اعلق تعليق مهم صراحه، يعني في كثير تعليقات، يعطيكم العافيه، محاضرات ممتازه، بس في تعليق مهم اي ثينك لازم نحكيه. اولا بالنسبه لا اي ثينك اتس امبورتنت، لانه ذكرنا انه ما في عندنا انتي اريثميك دراجز، وفعلا يعني هلا جديد صار في عندنا فلاكينايد وفي سوتالول اكشلي بالبلد، ولكن برضه ليميتد سبلاي. اي ثينك وي نيد تو دو مور ورك، وانا برضه بتفق انه اكيد ريذم كنترول وذ ابليشن از ماتش بيتر اند سيفر ذان انتي اريثميك دراجز. وبالنسبه للهارت فيلير with reduced ejection fraction, we have to emphasize there's mortality benefit. الموضوع بطل انه المريض بيصير symptomatic less symptomatic. في عندنا mortality benefit with heart failure with reduced ejection fraction مع AFib.
I agree with you, Dr. Laith. I think that's a great idea. And as a matter of fact, maybe us as Jam'iyyat al-Qalb, we could kind of write these medications that we think are important and needs to be available, and go ahead and provide them to JFDA. And if you want, the new head of JFDA is actually, we know her, she's from the University of Jordan. Her name is Dr. Rana Bedad.
Great.
And we could maybe get some...
بالمناسبة كثير منهم JFDA approved بس ما بنجيبهم لأنه فيش there is no financial benefit.
Okay, and before we end, just my last question for Dr. Natalia, because she had a wonderful presentation about athletes and sudden cardiac death. And honestly, Dr. Natalia, I have been seeing a lot of myocarditis, and I don't know if this is something new or what's going on. I've seen more myocarditis in Jordan than I was seeing in the US. What's your experience with myocarditis specifically? Like, do you see a lot of those, like MRI? Do you see a lot of MRI that's showing acute, and what would you do in those patients?
Usually, if suspected myocarditis, we perform serial ECG, echocardiography, and laboratory test for acute phase reaction, rheumatism. And,
yeah, what would you order?
Medicine?
No, for lab tests.
lab test, C-reactive protein, SR, CBC, anti-nuclear antibodies, ASLO titer.
Yeah, and I noticed in your in that slide that you put in the U.S. myocarditis is the third most common cause of death, of sudden cardiac death, and I think it might explain some of it in here. And I think it isn't a question, but probably we should work on a registry for sudden cardiac death in Jordan.
Dr. Mohammed, we see more myocarditis in pediatric age. The problem is really to differentiate between myocarditis and cardiomyopathies. And especially the presentation, it's acute, but oftentimes it's acute on top of chronic.
Right.
It's a real question, because the prognosis is different in both of them.
In pediatrics and adults.
Yeah.
It's a killer in adults.
Yeah.
Thank you.
Yeah. Yes.
True. That's true.
Yeah. Absolutely.
Rather than
Yeah, absolutely. For those who didn't hear, cardiac MRI is very important, and it was Doctor was sharing his experience during the COVID era.
Right.
I completely agree. Yes.
Thank you everyone. We
Thank you.
appreciate it, and you all have a good night, and see you tomorrow. Big day for pediatrics.
Thank you all. Thank you very much.